and that too to talk on a topic which is very, very important, where we are planning to save two lives, not of mine and my dear friend Dr. Alok, but the woman who is coming with GDM and, of course, the fetus or the future baby. So GDM is actually not merely a maternal diagnosis; it is a fetal metabolic exposure condition, and if we accept that the maternal glucose directly is going to program fetal outcomes, then the quality of monitoring becomes central to care. It's not moving. Yeah. So India actually carries one of the highest GDM burdens globally. Why? Because the Asian Indian phenotype, where we are seeing higher visceral adiposity, huge insulin resistance, and the peculiar diet pattern which we are having, the plate with more carbs, and ultimately it is ending up with postprandial spikes. While DIPSI, RSSD, all are providing structured screening and SMBG guidance, technology has evolved faster than our monitoring models which are existing already. So the real question is, are we detecting the full glycemic picture of GDM? Unfortunately, no. So why monitoring matters in GDM? Because maternal hyperglycemia is going to impact the fetal outcomes directly. The poor glycemic control in GDM, it is ending up with more number of babies with weight gain, macrosomia, neonatal hypoglycemia, NICU admission. So tight glycemic control is very much required in pregnancy, which will be effectively done with regular monitoring. That too smoothly done, guided with timely intervention as and when required. So, what are the limitations we are having with the existing models, so the conventional approach for monitoring? See, there is physical limitation. We are asking our patient with GDM to monitor blood sugar multiple times a day, fasting, post meal, post lunch, post dinner, or during bedtime, or even special timings as well. Of course, it is associated with pain, discomfort, can cause skin induration and reduce finger sensitivity. But at the same time, the physical impact, psychological impact, which is going to have not only to the mother, but the fetus or the future baby as well. So, the procedure related anxiety, multiple day pricking, fear of repeated pricking. So, it is going to impact the social life as well. One of our patients who was diagnosed with GDM, who was a teacher by profession, she said that I won't be able to monitor blood sugar with regular pricking multiple daily when it is not possible. So one another important thing, where we are going to advise to have 4 or 6 readings per day, it is going to represent less than 5% total daily glucose exposure. So SMBG, actually it is advised to the pregnant lady, but as you know very well that pregnancy physiology is dynamic. So blood sugar, it is going to be affected with the hormonal fluctuation, cortisol variation, the meal variability the patient will be having. We are making therapeutic decision based on incomplete data. So you can see the n number of the highlighted factors which is going to affect the blood glucose pattern of your patient. So any solution? Yes, definitely there is a solution. That is the continuous glucose monitoring data. If you are going to advise to your patient with GDM, it is going to help a lot. Why? CGM in pregnancy has already shown that many of the benefits, including achieving reduction in maternal HbA1c control, improvement in maternal time in target blood glucose levels, much more better when compared to the conventional monitoring system, and of course related to fetal outcomes as well. So, unfortunately, the many of the studies are lacking for this area with regard to CGM use in GDM, but one of the beautiful study, you can see the concept continuous glucose monitoring pregnant women with type 1 diabetes, where it has clearly shown that when comparing with the conventional approach, the continuous glucose monitoring along with the SMBG has shown significant reduction in HbA1c with CGM usage in pregnant women, and you can very clearly see that time in target was improved while using CGM, and hyperglycemia reduced in the CGM group. Unfortunately, the maternal outcomes, not that significant changes was noticed, but related to neonatal health outcomes, definitely it has shown that lower risk of large for gestational age, fewer NICU admission, reduced neonatal hypoglycemia, shorter hospital stay as well. So the key takeaway from this concept study was definitely the CGM is going to benefit these type 1 diabetes associated with improved neonatal outcomes, which are likely to be attributed to reduce exposure to maternal hyperglycemia. Few of the RCTs are there with GDM, but that's not significant to discuss in this platform. But I can show you few of the studies where there again it has shown that when comparing with the conventional approach of monitoring with SMBG, CGM has shown better glycemic control among the GDM mothers. And this has shown that higher TIR was observed with 93% with real-time continuous glucose monitoring when compared to the conventional monitoring approach. And a few other studies have also shown that it could pick up the hypoglycemia, that too the nocturnal hypoglycemia with the usage of CGM. And when the CGM data was compared with the normal uh, healthy mothers, there again the TIR was reduced in GDM was observed with some of the studies that was also being highlighted from our part of the world. So, of course, CGM has merits and demerits. You can very clearly see that limitations are there, but there are few, but many are related to technical or any standardization required while we are going to advise for our patients. And this was the recent meta-analysis which was published in PubMed, uh, seeing almost of 11 RCTs where there again compared the CGM versus SMBG in women with GDM, and these were the conclusion. So in women with GDM, the CGM improved likelihood of appropriate maternal weight gain. CGM reduced neonatal birth weight. No improvement in overall glycemic control, major maternal neonatal outcomes compared with SMBG. But the neonatal outcomes, which was discussed earlier in the earlier slides with type 1 diabetes, you can very clearly see that if you are going to miss the postprandial hike, that is, the fetal beta cells respond to peaks, not the average. But even if fasting or 2 hour postprandial looks normal, and if 1 hour sugar value is going to be high, the glycemic variability which is being continued during the entire time of pregnancy is going to affect the fetal outcome, ending up with macrosomia or other complications. So these are the key CGM metrics being highlighted. You can see it is not being shown with regard to GDM because lack of data. Still, we need to have more and more studies from our part of the world where TAR nowadays, the time in range is emerging as a better predictor than HbA1c in pregnancy. HbA1c actually underestimates excursion in pregnancy. Definitely, it is true that the real-time quality control should be maintained with the help of the monitoring system which we are discussing, that is the continuous glucose monitoring. Of course, ADA definitely highlights a word regarding the other types of gestational diabetes or the diabetes management or monitoring being highlighted here in the slide. So, why all not selected? Because severity is unpredictable during the time of diagnosis. Even if you are going to have a nutritional therapy being advised initially, patient can end up with higher blood sugars, resulting in the requirement of insulin for managing their glycemic control. So early control definitely will be preventing the complications later. And if you are going to prevent at least one NICU admission, definitely that cost matters. And if you are going to prevent that, means with the usage of this technology, that is the continuous glucose monitoring being done, definitely it is going to help your patient. So the ethical question, GDM is going to affect two. As I said in the intro itself, you are going to help or help your GDM with the lady with GDM and the child as well. So we are accepting ultrasound for all pregnancy. We are accepting anomaly scans universally. Why then we are not giving importance to glucose surveillance for our GDM mothers? So in an era of precision medicine, universal CGM should be recommended. It's not a luxury; it's an evolution. I strongly support the usage of CGM in all cases of GDM. That is my take of point. Thank you.